for the glitch. Yeah. Good afternoon, everyone. It's a pleasure to welcome you all to today's session under the Rare Info series by ORDI. This discussion on physical management in DMD is a vital step towards improving care and support for patients and families. I'm glad we could all come together for this evening. Myself, I'm Dr. Krishna Reddy, a consultant medical geneticist and a board certified genetic counselor, currently working at Progenics, Hyderabad. I'm truly honored to moderate today's session. Sessions like these are close to my heart because they don't just inform, they empower us. And today's topic on physical management in Duchenne muscular dystrophy is a powerful reminder of how care goes far beyond the diagnosis. And Dr. Vinitha Varghese is a dedicated rehabilitation medicine specialist. She trained at the renowned Christian Medical College, Vellore, with a heartfelt mission to restore dignity, mobility, and independence to those affected by disability. From her early medical days to leading transformative rehabilitation programs at Bangalore Baptist Hospital, she has built systems where none existed, introducing assistive technology, neurodevelopmental care models, diabetic food clinics, and community outreach services. With global exposure through her observing at Phoenix Children's Hospital, Arizona, and deep grassroots impact across India. Dr. Vinitha brings a rare blend of clinical excellence, innovation, and compassion to every life she touches. It is an absolute honor to welcome her today as our distinguished speaker, consultant in physical medicine and rehabilitation. Dr. Vinitha brings a multidisciplinary perspective to neuromuscular care. Her work spans crucial areas like post COVID recovery, stroke, spinal cord injury, and child development. So, as we explore this topic, rehabilitation management in DMD, we are privileged to learn from someone who has not only just understood the science behind rehabilitation, but who has also seen and created its transformative power in real lives. So, extended a warm welcome, ma'am. Welcome to the conversation with ORDI. Over to you, ma'am. Yeah.
Thank you, Dr. Krishna Sai. That was a very, very kind introduction. I'd like to thank ORDI for their initiative and also inviting me to give this talk. Narvi Hospitals, where I currently work, for giving me the freedom, to do this presentation. And the most important sort of team that we have built at Asare, that's the Assistive Technology Center at Baptist Hospital. The team consists of Ms. Mahima Paul, Mr. Emmanuel, Mr. Samir, and Mr. Arthur. So without whom we wouldn't be able to have any basis about this talk. So I'm going to sort of dive in. Most of the guidelines that we follow are still from the 2018 guidelines, and with regard to diagnosis and management of Duchenne muscular dystrophy. And so most of our clinical practice also sort of relies very heavily on these guidelines. So in PMR, most of the time we are talking about trying to, one is see what the child can do, and if there's something that the child is unable to do, see how we can help them achieve that goal. If not, provide adaptive devices to reach your particular function. So most often we're dealing in the very early stages, we're trying to prevent contracture and deformity. And also, especially in this population, it's very important to provide the appropriate exercises, because largely there's a lot of misinformation around about what exercises these children can do. And of course, orthosis and equipment, and like Dr. Krishna Sai said, a lot of assistive technology. And finally, because we work in a multidisciplinary team, we also look after fractures, and we'll see how that plays a very vital role in this population. So when you say contracture and deformity, one of the most sort of easiest ways that all of our children undergo actually is stretching. So this stretching routine is actually, we ask most of our parents to do it every day. And this is something that we would prefer for the parents to do and do it at home, simply because we believe that the child shouldn't be spending all of their days in, a therapy center. So if you see, most of the children will have a home program that is given to the parent. And so for the lower limbs, we're really trying to focus on our ankle, knee, and the hip. And with the upper limb, we're trying to get our forearm muscles and our wrist and finger muscles stretched. So if parents ask actually how many times you should do it, we usually have a 10 on 10. So it's 10 count, 10 reps. And how often is every day is possible, if not on a minimum of 4 days in a week. So orthosis plays a very, important role in minimizing as much deformity as possible. What is very important to remember is every child sort of varies in size, length. So it's important that each child gets their own orthosis. And one of the things that parents ask is, do we have to start now? So we try to start as young as possible. And of course, if a child comes to us a little later, we say it's never too late to start. So when you talk about orthosis in the ankle, we are usually saying if the ankle range is less than 10 degrees, then we say to use these splints, and these are night splints. So typically the child wears them to sleep. So you get, at least we're assuming each child gets about 8 hours of sleep. And so uh, that's actually what our aim is for. So 8 hours of sleep time using your stretching splints. And finally, this is during what we call the ambulatory phase. When you have, by the time the child sort of decreases in ambulation, then sometimes we say to shift your AFOs during the day when the child is sitting. Now, why we do this is because when the child is sitting, it's important, later in my talk, we'll talk about wheelchairs and seating. So when this comes into place, if the ankle doesn't sit well on the footrest in the wheelchair, this causes secondary pressure on both the knee and the pelvis. So this is why we would like the ankles to be in position even during sitting. So that's when, we shift from A4s at night to A4s during the day. A4s is something that we actually say, so there are actually two indications for this. One is if we see a child who's walking is sort of slowed down over the few years, and also if we see a bone density that is on your DEXA scan, that shows signs of osteoporosis really. We want the joint to start bearing more weight. So this becomes useful in children who don't have enough support to stand by themselves, then we have to give them external support. So the KFO becomes a way to allow for supported standing. So we can do this either with the KFO and use a wall standing system, or we can use something called a gaiter. So in this, we're doing two things really. One is we're getting a good hamstring stretch, so preventing deformity at the knee. And also we're getting adequate amount of support for the joints so that the child is able to weight bear longer. When it comes to upper limbs, I feel like earlier we used to not pay as much attention earlier on, but now even the children whom we describe as ambulatory, we make sure we check for tightness of the fingers. So this is important because later on when the child, is unable to walk, one of the things that's important is for them to be able to use their hands for their functions. So what happens is we prescribe hand splints if we find tightness, and usually these are given at night when they're sleeping so that during the day they're able to use the hand. Serial casting. So when we are talking about deformities other than orthosis, another way to sort of correct really some amount of deformity is by serial casting. Grossly, this was used, in developed countries much early on. Like it's not in as much practice now. Some of the difference in deformities can be why, it's sort of phased out in the West, whereas we still use it as a good tool here to sort of correct deformity. So what's a goal really here? So where once we've done a couple of casts, so maybe in a year we've done maybe 100 or 50 casts. So what happens is children tell us a couple of things. One is they notice that their tightness in the calves are better. Two is they're able to walk more freely. And three, their falls have decreased. So when we cast, especially in children who are walking, what we're trying to do is make sure that they have good hip and knee strength. And if their ankles are becoming tight, usually if we're not able to get the ankles to neutral, or some people would call it 90 degrees, then what we do is we offer casting as a method to decrease that tightness. So casting, typically what happens is we don't have, the guidelines doesn't come unfortunately from the 2018 guidelines. So interestingly, these guidelines for serial casting at least was taken from the parent support group, again in the US. So what happens is their advice is to finish casting less than within 2 weeks. So the reason why they say this is because beyond 2 weeks, as we decrease the mobility of the child, what happens, there's some amount of disused muscle wasting that happens. And so what we do is we try to ensure that we finish our casting within those 2 weeks. And yeah, so our aim here is not to just decrease, or rather get range of movement. Our aim here is to ensure the child is able to walk better, that the that the deformity is not the reason why the child stops walking. So how do you decide on casting? So there's sometimes we have to decide between, do we send the child for surgery, or can we try casting as a way to correct that deformity? So usually we describe that when we examine a child, what we're looking for is to see if really that movement feels like, is it bone on bone, which is a very hard and feel, or are we able to feel some amount of movement when we would describe that as a capsule sort of tightness. And finally, soft and feel is what normally you see when you do your range of movement. So ideally, we would prefer to cast on a firm end field and not a hard end field, because then this is when we are sending the child for surgery. So when we see a firm end field, then we are trying to see if we can gradually, with one or two, sometimes requiring 3 casts, if we're able to get better range of movement. So one of the things that sort of puzzle people is this sort of heel walking. If you notice, the heel of this child doesn't really sit on the floor. So is that really an indication for us to cast? Most often, actually, what we're trying to do with the cast is to make sure that what we're describing as a firm end feel comes down. The other reason why the child tends to heel walk, if not for the tightness, is weakness. So we have to make sure that we are casting when the child is actually having adequate hip and knee strength. A lot of parents ask, what are the good activities for our child? Can we do this exercise? Can we do that exercise? Now, most of the time we're sort of saying, nothing too forceful, nothing to get the child very tired. So one of the things, especially the younger children, if we sort of train them to understand how fatigued they feel, that is one of the best ways to say, okay, this activity is adequate for the child. So the child knows, before they get tired, that they should stop that activity. So the nicest activities for the muscle per se are actually swimming. So we do encourage swimming whenever the child is able to. A lot of, especially young boys, really like to cycle. So what we tell them is, if they are able to cycle, again, to know when they get fatigued, and also if they can take multiple gaps between their cycling. So it's important to allow them to sort of take breaks for their rest and conserve their energy. And so we don't want to, increase the risk of muscle damage. So this is something that we really discuss with the parents and the child. Some of the parents here, actually, if you notice, this cycle is an electric bike. So the amount of force that is required to pedal a regular cycle versus like a semi-automatic one is that this is much easier and the child gets the fun of the activity as well. So we do use a lot of devices in rehab, and so this actually is how we promote standing and weight bearing on the joints. So the standing frame typically, at least in India for now, looks like this. There are, if you sort of Google standing frame, you'll get very advanced devices. Unfortunately, importing those and bringing them here costs about maybe anywhere close to 3 to 4 lakhs. So this is a very interesting family where the child is very motivated. So what they do is they've managed to create a sort of modified standing frame, and they'll have a table across, and so the child is able to do an activity while standing. Yeah, so as we go on to devices, for us, sitting is a very important, you know, so I can't call it an activity, but when a child sits, especially when we notice there is an asymmetry in their walking and their muscle weakness. So over time, we see what we call a pelvic drop. So this is important because when you see a pelvic drop, what happens is the pelvis actually sort of is joined to your spine. So you will notice here in this picture, when the pelvis is tilted, the spine is also tilted. Now, this is important for us, especially in the early stages, because this is when it's still flexible. So this is a time that they sort of permit us to correct this so-called deformity. So what we do actually in our system is quite simple. We correct the side that is dropped, so we would give a higher cushion on that side. And so what we're really trying to do is take care of this initial pelvic tilt before it becomes, a bad scoliosis. So that is quite crucial in a very early stage, because once the deformity is fixed, we cannot do the same exercise here. So this happens in children who are sort of going towards what we would call as a non-ambulatory phase, which means they would require the wheelchair throughout the day. So it's important that the children get a modified wheelchair, because most often if we are not correcting the wheelchair, none of these deformities ever get addressed. So what happens is, over time, as the child's bone density worsens, and your vertebra sort of fracture over time, this this deformity becomes very bony and not fixable. So this is something that's quite important for us to address in the early stages. So most of the wheelchairs, if you notice, they don't come with a firm surface. So the team at Asre, they're very involved in making sure even the cushion that the child sits on is of a firm surface. So, and we also give side supports, as you see. I will show you another device. Yeah, so this is a child who got actually a modified wheelchair. So again, unfortunately, in India, we don't have pediatric wheelchairs yet. So even the smallest wheelchair size of an adult is too big for a child. And children who are not able to ambulate should be given the opportunity of freedom in a wheelchair still. And so this child can be independent with just a motorized wheelchair. So we've actually modified this whole wheelchair to prevent further deformity. I'll give you another example. So this is a young boy who came much later on. So if you notice, you'll see that without support, the spine just collapses. So it's important for us to be able to, the amount of support or force that is required to hold the spine straight is what we're trying to translate to the wheelchairs. This is much harder than actually what it looks like. So, but the team is quite dedicated to trying to do as much as possible for these children. So when we talk actually about fracture prevention, especially as the amount of what we call weight bearing decreases and you see progressive loss in bone density, it's important to be careful of fractures, especially because general rule of thumb is that once a child who is towards a non-ambulatory phase falls and fractures something, it's very hard to continue walking in these children. So when we talk about fracture prevention, we're making sure that home environment is safe, that they have some safety on uneven or slippery surface, and sometimes if required, home modifications. So the simplest way to make sure their home is safe for them is to remove obstacles along the way. Mostly you'll see wires around, you'll see, a disorganized home with toys around or carpets or even mats around. So those are the easiest things to trip and fall on. So that is one of the easiest advice that we can say is to get rid of these things. Now, a bigger challenge is accessibility in our public roads. So most of these uneven surfaces really take a toll on these children because they're just about walking with their muscle weakness. And if they trip on something as small as a small stone, they can fracture their limb. So especially when they're outdoors on uneven surfaces, we actually ask the parents to be a little more careful. Sometimes it might be like just giving additional support when they're walking. The other thing is to try those who are going swimming to wear pool shoes so that they don't slip on the water surfaces. And home modifications, really, we're talking about bars for them to hold, or if there's a bath seat for them to hold so that they're not slipping. For example, side rails. So a lot of children like to climb stairs. So when they're climbing stairs, we ask them, make sure there are handrails for them to hold on to. So this is a child that came to us, and in rehab, why or rather fracture management is a little more complicated. If you can see, this is a 10-year-old child who had a fall. So this child was on regular follow-up for a long time, but missed a couple of doses of zoledronate injection. And so what happened is this child fell and fractured his femur. And the challenge here was this child has had a lot of muscle weakness. So if we didn't address this as aggressively as possible, then this child could have stopped walking. So or the ortho team fixed the bone for us. And then one of the things that is important in this stage is this is over about 4 weeks of the child not walking. So what happens is when they tend to not be able to walk, the ankles start becoming tighter. So what we did in this child was to make sure that we had actually casted the ankles to prevent worsening of the deformity of the ankles. So once we did that and the child was given permission by ortho, once the bone had started healing, we started putting weight on this child's ankles. So he did not worsen in his deformity of his ankles, but also we started what we call partial weight bearing. And so this was after all of the fall and after a lot of the rehab that he actually started walking again. So this is most often, if you're not working in a team, what happens is you'll notice that these children actually find it very hard to start walking again. So trying to be very aggressive in their fracture management is important to prevent, the child from becoming non-ambulant. So pain, I think pain is actually, at least there's a lot of discussion about pain. There's a lot of pain clinics around. In this population, though, I feel like pain is maybe slightly lesser addressed. So often the pain can be because of many reasons. If their osteoporosis is not treated, they can have a lot of bone pain, they can have muscle pain. Sometimes the children complain of calf pain. So it is important as a rehab physician to understand why the child has pain, and also the different modalities that we can use for pain. So sometimes it might require medication. Sometimes we use uh, just a lot of physical therapy, like modalities in terms of heat, cold, in terms of electrotherapy. Sometimes it might be kinesiotaping, or so looking for why is an important question to ask when the child complains of pain. So that's the end of my talk from at least the rehab perspective of what we do right now in India, and hopefully we'll have more advances over the next years.
Yeah, that's an absolutely fantastic session. And actually, this is the very first time to me that I come to know there is a physical medicine is there, like where they treat for. I know the structural abnormalities called osteogenesis imperfecta, where the surgeons will use to changes in kind of bone deformalities. But when it comes to the cases like DMD, so it has to be, we have to moderately, it's a progressive disorder. At different stages of the disorder we have a lot of changes, and as being, in the phase of management, you people are doing an absolutely phenomenal job. It's a very pleasure to know this. And I have a little questions here. As you know, DMD is early onset, as you know. And from how can you look this like from pediatrics, the growth of approach from pediatrics to early adolescence, maybe at 12 years, 13 years. So how can you see that approach of different stages of DMD, different management planning of DMD? How can it changes accordingly?
Okay, that's a good question. So, what we've been noticing, is one is from a genetic point of view, depending on, what is skipped and what is not really.
Right.
So when you sort of look at a child, okay, this age group, you're sort of able to tell how the progression of the disease is going to be really. So, like you can have an 8-year-old that is, suppose you have two 8-year-olds, both are started on steroids at the same time. One is weaker than the other. Then you go back to the genetics and see that you sort of look at why, and then you'll be able to predict how the child is going to be over the next few years. And because we know we have the natural progression of disease, we sort of also are able to, I think, plan ahead in terms of priming the parents. That's also important, right? When you go from an ambulatory to a non-ambulatory stage. And so those are things that we are actually, at least Dr. Anne is our neuromuscular consultant that we work with. So there's a very careful follow-up of these children.
Right.
So once in 6 months they go to her. Most once in 6 months either they come to me, or once a year, depending on what stage they're in. So I think that's how we're able to plan both with the child and the family.
Right. But in particularly these kind of cases where we know the poor prognosis are there, so how can you deal with the parents? As being genetic counselor, I come across a lot of BMD cases and it's very tricky to us. But when it comes to you, so how would be to counsel the matlab, taking the care of parents, making them train?
I think that's one of the advantages of working in a team. I'll 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 give you the biggest example. So like Dr. Anne, our neuromuscular consult, she takes care of a lot of the counseling. If you ask me, the counseling as a rehab physician, what I really take care of is when the child goes from ambulatory to non-ambulatory. That is that is actually the biggest challenge that we find. So there are two things. One is, most often, if uh, parents don't like the idea of a wheelchair,
Right.
so
Right.
what happens is the child tends to fall, and we are really worried about the fracture risk. And also you're forcefully trying to get a child to walk, and that's a lot of effort on the heart, right? And with the pre-existing cardiomyopathy, you really don't want that to happen. So then we are actually, so one of the easiest ways to actually do this is to do peer counseling. So one of the parents who is using a motorized wheelchair talks to another parent who's not really keen on it. And so,
Mm-hmm.
but when a lot of parents are receptive when they realize the child has become more independent.
Right.
So once and the child discovers becoming independent, they're very
Okay.
happy.
Right.
So
Right.
that's how we sort of handle that.
Yes.
So if I answered just a part of your question, because that's the only part that we sort of
Right.
deal right now.
Absolutely. Absolutely. And yeah, it's a phenomenal job. As you showed a video where a boy with his sister, if I'm not wrong, yeah,
Yeah,
walking with his sister. So practically, it's not possible if he doesn't come to you or with the clinicians. So a lot of efforts made him to walk again, and along with continue to take his moderate actions. That was a fantastic job. And yes, being in this community, I'm feeling proud. So let's see about the questions. Are there any questions? You can just throw. Yeah, I think we have a question in Q&A. Can any CSR be involved to get well-designed wheelchair? Wheelchair tailor-made for Indian kids.
well, that's great. So, actually, one of our biggest issues right now, at least in India, if you see how wheelchair distribution happens, like organizations will take like 100 wheelchairs of the same size, same make, and just give it to anybody with a disability. And obviously, everybody's clapping for it. Oh, it's the person got a wheelchair, right? So, a lot of the times, what happens is that can actually cause more deformities in the children. And we've seen it happen. So, what happens is once a child becomes non ambulant, they take the shape of the wheelchair. So the child can sort of curve up into like almost like a ball, and
Right.
which is quite sad. So how we do it actually, um, we have a large population of children who need help, right?
Right.
So
Right.
so what we do is we try to create a list of children whom we need to support, at least from our clinic. And how we described is we beg, borrow, and steal for these children. So we are so then if there's an organization that's willing to help us, then we make sure that each child is provided with a completely modified wheelchair. So we did, I think, in October 2024, we took only 5 children with
Okay.
neuromuscular issues, and one of them got a motorized wheelchair, completely modified, which is quite expensive. The others got manual wheelchairs, again, completely modified. So if you ask me, can CSR help with these children? Definitely, and it can be modified. I think that is important to educate people. If that answered your question right.
Yes. So yeah, but as you mentioned, tailored wheelchairs are definitely a tricky part in making an effort to do the tailored thing, and as you mentioned, it's expensive too for the families from below poverty line or from the poor background. So yes, so that's a tricky part and some challenges. This is and for me, as being a genetic counselor, we have seen cases, and especially these TMD cases also cope up with neurological implications and sometimes with global developmental delay, delayed milestones. A lot of things are there. Sometimes people comes up with fully dressed. I've seen a case where the baby is completely dressed with woolen dress, completely dressed and shoes. Everything was quite good. So in such cases, we definitely ask them to remove the dress and open the matlab, to look the position of the baby, at least try to make them walk. But I felt that the rural areas where like semi-urbans, they can't accept the thing. Like yes, there is a condition, we have to go through the testings and all. They are not ready to accept. They said it might be a temporary thing or he might be all right. So I think the lack of awareness is the major factor where we are still at least back ahead to make things right. yeah, as being you, people are in forefront. You can have a lot of things to make sure people make aware. And yes, we have ORDI to make things for rare disorders. Are there any questions? I think some more questions are there. Yeah. What type of shower chair is advisable for young adult DMD person who is obese? Getting a good shower chair for such cases is a uphill task. So that was the first question. And there are a couple of questions are there. Do I need to read again?
No, no, no. It's okay. So the shower chair actually, that's interesting. Very few families actually think of a shower chair. So I think two things that you need to see is if this is for your child, see how much of support they need in terms of the back. If the trunk control is good, then you should be able to manage something without a back support. There are chairs that what actually unfortunately here they're called commode chairs. So those are chairs that we are able to use in the washroom, and those are also chairs that have wheels. So it will be easy for you to transfer from the bed to to this commode chair and then wheel that sort of into the washroom. So this is actually something that you can get online. A couple of companies that we tend to rely on, usually Vermeeren, those sort of standard companies, simply because they last longer. So that should take care of that.
Okay. So I think she has thrown some second question. What type of bed and mattresses do young DMD adults need? Those who have scoliosis and those who underwent spine fusion surgery. Should an air mattress be used? Mattresses be used here.
Okay. So I'll answer the second question first. So an air mattress usually we use to prevent pressure ulcers. So if your child is unable to turn, then using an air mattress might be useful, but it's not something that we advocate really, because I'm sure somehow you're able to turn him a couple of times at night. So that should take care of most of your pressure source. Um, the first part of that question is what type of air mattress, right? So, sorry, what type of mattress? Um, so usually we say if you can get coir and on top of that foam so that it is not too hard and it is not too soft. That is typically our advice in terms of the mattress really.
Okay. And we have a question from Vidya. My son has Hunter syndrome, has scoliosis. He is now 14, has been wearing braces since he was 10. Curve hasn't progressed. We have also seen some corrections. My question is, how long does he need to wear the brace? Also, I want to know if bracing will cause acid reflux because I'm seeing this since a year now. That's what the question.
Okay. So how long does he need to wear the brace? So usually what happens is because this is, in hunters really the we're trying to we have two things here, right? You have both the bone disease and the muscle. So I would say anyway prepare for him to have the brace until he's 18, and then you can discuss it with your physician after that. But if you're seeing correction, then that's a good thing to just keep using the brace. The second one is usually bracing does not cause reflux, acid reflux. This might be something that you would want to take up with your pediatrician, um, you know, simply because that should be addressed. And usually, I've never known for the braces to cause acid reflux. So, I would definitely take that back to your pediatrician.
Okay. So let me know what are the questions are there. If any questions are there, just put in the comment section. So, what are the advice you'll give for the caregivers, for the parents, especially who come to you?
Usually in clinic, I think the easiest advice that we give in terms of stretching, make so in the presentation I was talking about stretching, I was talking about orthosis. That's definitely the advice that we give them in our outpatient. So if we see any sort of deformities that are setting in, we sort of give them ideas on how to how to minimize that as much as possible.
Right,
So grossly that would take our OPD at least for Duchenne. So
right, right. Yeah, it's integrated part of a teamwork. Yeah,
yeah, yeah. We have a couple of questions.
yeah. Uh, how to address good food rest and wheelchairs, as even the best one does not support them properly. What options do these kids have?
So this is actually a hard one. So one of the things that we do is, at least if the child is buying it for the first time, we send them to a few companies whom we know do these modifications. So that is one, because if the foot plate is not, is not positioned well, this is like sort of leading to all these other deformities. So really what we do is certain wheelchair companies that adjust the foot plate for you. And if you had noticed on the presentation, so if you have a good orthotic clinic nearby, what they should be able to do is modify your foot plate as much as possible. And I think that's the best option if you already have a wheelchair that, um, can't be fixed by your manufacturer.
Got it. And we have a question from Anush Mishra. Can we do such awareness sessions in rural areas, even in North Indian states, where we still see kids with such situations?
I feel like that's a hard one, you know. Um, so we do see children, so because the clinic, or rather the team is a referral clinic, so we do see children from the north as well. And unfortunately, what you notice is their deformities are a lot worse. Um, this can be a lot of reasons why. One is the family is either not willing to support this child, or they don't get the right treatment at the right time. uh, can we do it? I hope so. How do we do it? Maybe ORDI should sort of help with that.
Right. So yeah, we have next question. What type of stretching exercises should one do and one need to avoid if one has undergo spinal fusion surgery from T2 to pelvis with pelvic flexion?
Okay, so in this situation, I would still make sure, by this time we're expecting, um, like in your child, if your child has tightness of your fingers and your elbow, I would ask you to make sure that you're stretching that, simply because I hope that your child is on a motorized wheelchair and able to use it. So you don't want that the sort of hand to get stuck like this. So I really think that that's something that you should stretch as much as possible, hand muscles. Now if sleeping is hard because of the knee, then I would ask you to stretch the hamstring as well. Gentle stretches, again, 10 counts 10 times, and that's all.
Right. And we have a question from Sushma. My sons sleep in knee folded position, like how to correct it, and knees is in bend position. Yeah.
Okay, so this is when we are thinking of a hamstring contracture. So sometimes it really depends if what is our goal really. Um, if your child is able to sit on a wheelchair and this bend knee is not affecting the child, I would ask you to, if the foot plate is, the support behind the calves on your wheelchair, if that is adjustable, then if you can use that to stretch out the hamstrings, that might be one position. um, the second thing is sometimes we use gaiters, but I'd really need to know how much of tightness there is in order to advise this. So, we have ranges. So that is something that we would, decide on based on that. So it can go from stretching to using gaiters to, uh, to making modifications on the wheelchair. So these are things. And
Right. And we have question from Masundara. It is possible to work on a template on how to modify. Vellore has advanced knowledge. If any tech team work on it, it will help. Oh, he's suggesting. Yeah.
yeah, no, so we do have certain templates, but unfortunately, it's sort of not out there. Simply because we need to make sure that we are checking a few of the deformities before we can offer that suggestion. Um, and I think that information should be available with your physicians. Uh, but I would totally understand of wanting to make that more accessible.
Right. So we have a question from Hardik. When we compare tilt table standing, cut to therapy, is serial casting is much better alternative to correct the deformity.
Yeah, so this is actually a very interesting debate, and um, so is that a statement or a question? So if it is a question, then one of the things is there are children who do well on the cut therapy. I will not deny it at all. So if cut therapy just for those who aren't really, aware, is they use these old form of bandaging, and they get the child to stand on a tilt table. Now, what happens is when you're using that, um, some of the children do really well. Like, you can see their deformities sort of get corrected and they continue to walk. But there are some children whom we know who've actually worsened quite badly on getting the cutter therapy. Now, the reason why this happens is, like I had said, when we serial cast, no, we are making sure that there is good hip and knee control. Doing this on somebody who has lesser hip and knee control will actually make them stop walking. So this is something that the family needs to be aware of before they do this. So we are not against cutter therapy. So those who find it useful can please go ahead with it. And yeah, and if you find it beneficial, then great.
Yeah. And we have a question. Is there any prospect of getting robotic arms for DMD kids? That's first question. Robotic.
Um, so actually, currently, how whatever robotic arm is, I mean, robotic is they use what you would call a sort of neural connection, right?
Computer.
So yeah, so that when that neural connection is intact, it's actually possible to sort of do the movement. So is it possible? We'd have to ask the tech guys. But I do know that they had tried this on in one family abroad, but not really for upper limbs, but more for lower limbs. And just as a support, so the machine actually does the work of the muscle. So they did try it actually.
Okay. Uh, and then we have ma'am have one more question. Carpal tunnel syndrome. Will hand splint during sleep in night help improve carpal tunnel syndrome?
Okay, so if so now usually carpal tunnel we approach it, uh, based on what we find on your nerve conduction. If it is mild, definitely a night splint will help. Basically, we are trying to decrease the amount of the force here. So keeping the hand splinted 15 to 30 degrees will help. The other thing that will help is if it is not getting better, like a moderate sort of carpal tunnel on the nerve conduction, then we sometimes offer injections. Um, the final step is if it's severe and you don't want the motor neuropathy to worsen, then we definitely say surgery. So, yeah.
How to weight loss Duchenne muscular dystrophy?
Mm. So actually, all of the children who come to the team, especially because they're on steroids, do get sent to a dietitian. They all have a personal plan of what to eat, what not to eat, and this is this is actually a very detailed discussion with, I feel like individual families to know what type of food you generally eat and so to modify it, right? So this is something that is done. So basically they go on low carb, high, like slightly higher protein diet. So
Right. Yeah. So I think we are done with questions. Yeah, thank you for your time taking, to answer all the long questions. We hope we connect soon with a lot of like these sessions. I think no more questions here. Yeah, I'll like to thank ORDI for making things like this and making sessions to bring awareness and making parents and advisory groups to be get benefited through the all kind of these sessions. And especially Dr. Vinitha, thank you so much to having your time at this keynote and explaining all these things and to clearing all these doubts. It's incredible work. Thank you so much.
uh,
Yeah,
thank you. Thank
thank
you
you.
for, yeah.
Yeah,
Thank you, Dr. Vinta, ma'am. Thank you, Krishna Saigar.
thank you.
Thanks a lot.
Right.